Today I'm going to talk about deep brain stimulation in Parkinson's disease. And see, deep brain stimulation is not something new. It is almost 20-year old after the approval. So let me share my slides first. So as I mentioned that today's we'll briefly discuss about deep brain stimulation. In this short video, I'm going to discuss about the criteria, the patient selection, who are the best patients for deep brain stimulation, and then is there any age cutoff where DBS is not effective or can have more complications, and what are the approvals for deep brain stimulation in Parkinson's disease. So DBS was approved by FDA for advanced Parkinson's disease in 2002. So now we are in 2022, which means after approval, 20 years have passed. But still, some people feel fearful or scared that, it is experimental. It is not like that. It's an approved treatment and practiced all over the world. And then about a decade later in 2013, based on the data of early STIM trial, DBS was approved for earlier stage of Parkinson's disease also. And this led to the most recent FDA approval for patients who have disease for about 4 years, out of which 4 months of motor complications, and which are not adequately controlled with the medications. So if you look at this, approval stages, first in 1997, FDA approved ventral intermediate nucleus of thalamus DBS for tremors. Mainly, tremors used to respond better. So it was approved about 25 years back for that. Then 5 years later in 2002, FDA approved subthalamic nucleus DBS for advanced Parkinson's disease. But one of the drawbacks for doing only for advanced PD was that many younger patients could not benefit. And then multiple trials were done. One of them was early STIM trial. And then, after that, it was approved in 2017 for earlier stage of Parkinson's disease also. So who are the patients who are best suited for, doing deep brain stimulation? So if you look at the main criteria for inclusion are that the patient should have definitive diagnosis of idiopathic Parkinson's disease. So we should spend some time, initially it may not be very clear that, if somebody has tremors, then look for, clinical features of tremors, rigidity, bradykinesia. And then once you suspect Parkinson's disease, then give them levodopa and, make sure that they respond to levodopa. And they should also have levodopa-induced motor complications like on-off phenomena. So after taking levodopa, they should show reduction in the tremors, rigidity, and the gait should improve. And then many times they can have dyskinesia. So after giving levodopa, after 30 to 60 minutes, they have involuntary movements of hands and legs, usually more on the affected side. And as the effect of levodopa wears off, dyskinesia is also reduced. And then they should not have dementia or active psychiatric illness. So these are the patients who do very well with deep brain stimulation. Who are the patients where DBS should not be offered? So one is atypical Parkinsonism, or also known as Parkinson's plus syndrome. So in that, patients who have multiple system atrophy. If patients have autonomic dysfunction, initially in the course of the illness, like, if they have drop in the blood pressure, postural drop, or if they have bladder symptoms, erectile dysfunction. So this prominent autonomic dysfunction is not a feature in early Parkinson's disease. If it is there, it could be multiple system atrophy. Similarly, cerebellar ataxia is not a feature of Parkinson's disease. If somebody has ataxia early in the course or at any time in the course, it could be multiple system atrophy. Progressive supranuclear palsy is another condition which can sometimes be confused with PD, and these patients have gaze palsy. So, while reading newspaper, you'll see them holding the paper like this because they can't see the lower half of the field. And as they come down the stairs, descending the stairs, again, they have difficulty in seeing the stairs, so they can fall. And them in their axial rigidity is more than rigidity in the arms and the legs. So such patients could be having PSP or progressive supranuclear palsy. They don't benefit with deep brain stimulation. And then dementia with Lewy body is another condition where patients have prominent hallucinations, and they don't respond to levodopa. So, and any patient who has dementia, significant dementia also should be excluded. And patients having severe depression or psychosis also are not good candidates for doing deep brain stimulation. Now, should we offer deep brain stimulation for older persons? So most clinical studies on DBS have excluded patients who are older, typically above 75. But there is a good review article where they have analyzed the data of all the DBS trials until 2014. And they looked at the complications in older versus younger people. And there's no difference. So post-operative hemorrhage rates and wound infections were almost similar in both the groups. So DBS should be offered to older people also, any age person, provided they are physically fit and they're likely to benefit based on the criteria that we just discussed. Who are the patients who will have good outcome after doing deep brain stimulation? Younger age. So we should offer DBS early. As I mentioned, somebody having had 4 years disease duration with 4 months of motor fluctuations are ideal candidates for offering DBS, short disease duration, those who have good levodopa response. So patients who don't respond to levodopa, like they are same before or after levodopa, they are not the ideal candidates. Patients should not have significant axial motor symptoms. So those with appendicular motor symptoms in, distally in the arms and the legs, they do better. Patients without dementia and patients who have stable psychiatric conditions. So these are the features of, patients who will do well with the deep brain stimulation. Now, many people are scared or fearful about DBS because they feel that it's a brain surgery, so there could be complications. But that is not true. Most large series have shown that it is safe, and the rates of complications like cerebral hematoma, infection, erosion of the skin, or mental status, behavioral changes, it ranges from 0 to 5% and can be easily managed. So I hope with this, it is clear that deep brain stimulation is a very useful stuff for patients who have idiopathic Parkinson's disease. And I'll be happy to listen to your feedback. And if you have any comments or queries, please type it in. Thanks.